I guess we can continue this conversation. So thank you all for having me here, for inviting me today. And I was tasked with a short presentation, 15 minutes. I'm going to talk to you about food safety. It's different. This is a little bit different. So I work with the School of Veterinary Medicine. My name is Alexandra Calle, and I am a professor of public health, food safety, and do research in food safety and food microbiology. And so that's kind of a little bit what we're going to talk about today. So the task is discuss raw pet food. And not that we haven't, that we have done research on that, but more the discussion will be on the perspective of raw pet food in association with food safety and how that can impact our health. So I'm not a veterinarian, so I'm not going to talk about animal health. And so in preparing this presentation, one of the first question I asked, like raw pet food, but why do we want to feed our animals with raw pet food? And so that's the question, like why raw pet food and what is in raw pet food? So I have a problem that's called H, so I have to go back and forth. So, so in our, thank you. So what is in raw pet food? First off, so everything will be raw, right? So they put meat that is raw, chicken, beef, lamb, undercooked organs. Sound a little weird, but that's how it is made. And bones, heads, feet, not or unpasteurized milk, eggs, and in some cases they will put vegetables and fruits. And not being a veterinarian, perhaps for me, is difficult to understand the benefits, and I'm not even going to argue against that. There might be some health benefits, as I found in some of the companies they say, well, it's good to feed the animals with ancestral diet. I don't know exactly what that means. I guess if we maybe eat our ancestors' food is healthier, I'm not sure. But so we in general, and when I say we, I guess I'm putting together pets and humans as just thinking about the consumption of the food. So in any raw protein from animal sources, we will find bacteria. Not in 100% of the lots that we test, because we do testing for meats and things like that. So we don't find pathogens in every single lot, but we do find, like actually we finished a project where we found 10% of our ground beef has salmonella. So just make sure you cook your hamburger. So there, it is a chance that you find Listeria, Salmonella, pathogenic E. coli, parasites, and of course, we might be able to find H5N1 virus. And so if we still wonder, is it really a concern, a food safety concern, or a concern for the animals to provide them with raw food? So there have been cases. So this company, Blue Ridge, and I'm going to mention a few companies. I have nothing to do with them, and I don't have anything against them, but this has been in public news. So this company had a recall, and they call it a voluntary recall. When there is a recall, it could be animal food or pet food. It's voluntary, but it's like FDA is suggesting you might want to recall that food. So it becomes voluntary. So they recall this food because it had salmonella and Listeria contamination. So they actually have had 2 recalls. One in January 2025, where they had this raw pet food contaminated with salmonella, and also they had another one in April where they found in their in this product they have salmonella and Listeria contamination. So you may wonder, well, is that going to affect just the animals, or is it going to affect us? In this case, we don't have, or they don't have any report of human diseases, but it is a big concern. There have been many foodborne outbreaks where humans have been infected with pathogens in pet food. Actually, I was telling this morning somebody, I'm not going to tell the story, but I'm going to tell the story. 23 years, I have a 23-year-old boy. I have 2 children, but 22 years, my son was hospitalized for 2 or 3 days. I can't remember. It was terrible at that time. And I believe that it was from eating the pet food, because I saw him eating the pet food. And so he was hospitalized for 2 or 3 days. I can't remember. It was so bad. Like now I can smile and say that, but you know what is having a 1-year-old boy in a hospital. And I believe it was also salmonella. So outbreaks happen, and in the US have happened. Also, we had this case from several years ago in Canada, just as an example, also of the food safety or public health risk of pet food being contaminated. In this case is E. coli 0157 from frozen raw pet food. Salmonella, also another outbreak where 7 people were associated from, or not associated, infected with salmonella, and 6 of them were kids. I guess my kid could be part of this statistics. So I think maybe they eat the food. I don't know how the kids get infected. Maybe they eat the food. So CDC, FDA, even the AVMA, they're saying, is it worth the risk? Do we really need to feed our pets with raw food? And CDC, this is from a copy from their website. CDC is not recommending feeding raw pet food or any raw treats to the pets, dogs, and cats. And FDA also says raw pet food diets can be dangerous to you and your pets. And AVMI also is discouraging the use of raw pet food. So, but what is the concern, and how do we get sick? I mean, the exact route of transmission, or how we get the pathogens from the pet food, from the raw pet food, that we don't know. But I found several pieces of information that I thought that were interesting. So this is a research, I believe it was like 2020, and this research was conducted after an outbreak where they had like 165 people gotten sick with salmonella from pet food. And so in the US, for this research, it was a food safety, I mean, for humans research, where they investigated pet owners and their habits and their interactions. Of course, if you have a pet, you're going to hug your pet. You have a pet for a reason, right? And so they list here the different behaviors, like how often, or people who kiss them. I think everybody does that. People kiss their pets, they're licked by the pets, they cuddle with the pets, they sleep with them. Some people wash, some people don't wash their hands when they're in contact or when they're feeding the pets. But something that was super interesting to me is that portion there in blue. Let's see if I can use this. 78% of the pet owners are in, this is more summarizing the idea, but they're unaware of the hazards, food safety hazards associated with the food, with the pet food. So people are usually not concerned. I don't know if it's the case or your case, but people are not very concerned about getting sick with the food your pet is eating, because you may assume, I'm not eating that food, right? So why am I going to get, bless you, why am I going to get sick? And even some people wonder, are we getting sick really from the pet food? Are we getting sick from maybe the feces and the pathogens that are being shed by the animals? So our pets will shed pathogens, including the virus, and they will shed salmonella and E. coli and other pathogens, and it all depends on their diet. Some of them, I don't know if I don't think that they're carriers, but in some cases it's more associated with their diets. But based on this paper and other papers I have found, it's about 2% of animals will shed, pets specifically will shed salmonella or E. coli. They will shed listeria. Again, it all depends on the diet, and also it depends on several type of things, and you can find even more information. And so that's what is shed by the animal. But the raw food, the raw pet food, FDA a few years ago, they tested several samples of raw pet food. I don't think they haven't done that. They have not done that with the HPAI. Unfortunately, I would have loved to bring that data here. And I understand the focus is HPAI, but I think by discussing these bacterial pathogens, we can correlate with the hazard. They tested raw pet food, and they found 32 of the samples were positive for Listeria monocytogenes. Actually, they did not find, almost zero on the processed or cooked pet food. 32 samples with Listeria monocytogenes, 15 with Salmonella, and 8 samples with pathogenic E. coli, specifically chigatoxin-producing E. coli. So there is this trend of giving the animals pet food, raw pet food. We know that what is the hazard, and so this is what we do. That's why we have pets. I don't know, maybe a food safety person won't do that, but still, that's what we have pets. So our pet will eat the raw food, and then we allow the pet to kiss. We hug the pet, and we're in contact with them. So that could be perhaps a potential source of transmission. Also, quick story: a couple of years ago, we were doing a research, not with pet, but with pigs, collecting feces actually. And somebody else was collecting a different type of sample, blood sample, and this piglet was about to die. It wasn't part of that portion of our portion. Was easier. We just grab feces. That's it. I don't know. Maybe the lady thought that blood is better than feces. Well, the pig was dying, and she tried to resuscitate the animal by giving him or her, I don't know, like mouth-to-mouth resuscitation. And like a couple of days later, she got diarrhea, and she said, "I don't know what I ate." I'm like, "Let me tell you what you did. You kissed a pig." So of course, it was even a little bit more than that, and the animal unfortunately died. But so that might be maybe that. So unfortunately, not just Salmonella, not E. coli only, and Listeria, but now we have this not so good friend, H5N1 in virus. So they have found, and there have been recalls of pet food, specifically raw pet food with the virus, and they have had cases of house cats in Oregon, California, and other states diagnosed, and even some that have died, and several recalls already. So of course there is a concern. They have not, based on what I've found, there have not been association between the raw pet food and which H5N1 and human disease, but there is a risk. We have seen already several outbreaks with other organisms. We know that, and Dr. Abdul already mentioned this, the virus can be easily killed with pasteurization. We know that the virus can be killed with just cooking and treating the food, but we insist that pet food can be a thing. And FDA has been also recommending manufacturers, if you're making raw or pet food in general, you have to include now this virus within your food safety plans. There is not a lot that we can do to protect ourselves as pet owners, except for, I don't know, just cleaning practices, not letting the pet perhaps lick your face. I don't know. So it's not a lot that we can do. I guess it's more up to those processing factories or manufacturing facilities to ensure that the raw pet food is free of pathogens, which is very, very difficult for a reason we learned 100 years ago that we have to, or a few hundred years ago, we learned that we have to cook food just to reduce the cases of infections, right? So the other thing that they do, FDA, is labeling. I think that might be another way to protect consumers, but still, you have to be very aware and very cautious. Labeling when the manufacturing facilities are labeling the pet food, they are supposed to put this, and this is copy and pasted directly from the FDA website. They have to have the legend saying this may contain pathogens, which is expected. And so just be cautious, keep frozen, thaw in the refrigerator, but still, if you have pathogens, they will be there because it's raw. And while human infections remain rare, experts stress with the avian influenza, the experts are stressing the importance of proper hygiene when you're handling your raw pet food, or even in your contact with your pets. So it's very important just to be very, very aware of that. And just to finish this very quick presentation, just keep in mind that if we know, and as Dr. Abdul talked for an hour or an hour and a half telling us about the amount of animals that are being associated with the virus if we are eating or allowing our pets to eat raw food that would be a risk. And I guess I did it in 15 minutes, exactly as I was told. And I did not practice the 15 minutes. I've been talking for 25 years. Well, thank you so much. If you have any questions, don't ask me about animal health, please, because I won't know. Well, you can ask, like, maybe you, any questions? Because also, Dr. Abdul said for you, you can take questions, or my questions are at the end for this. It's like, if you have questions. Mhm. Correct. I think so. I think that's part of, and even based on papers, I guess that being a scientist, we always say things, not I guess, but based on papers. I think that will be the case. This is that awareness that it won't make him sick, and I'm not eating that food. But certainly there is a way for you to be in contact with the animal licking you, and dogs lick you. So I think the awareness is one of the reasons, perhaps, because they don't think that will make you sick. But I don't know. I think the awareness, definitely. Okay. Thank you so much.
Thank you, Dr. Kaye. All right. So, may the panelist for panel 1 please come to the podium? And my MC. Oh, no. Oh, God.
Will you facilitate? Oh, good. So, great, fantastic. Because I was told to come and show this, so I'm going to do it.
Oh, okay.
All right. Yeah, we may need to better. These lights, we have to push them, keep pushing them where we want to. This basement is, so whenever you're on the top, hopefully we push them on, the red one, the red one. That's the climate.
Good afternoon, everyone. My name is Veronica Riojas. I am the Communicable Disease Manager for the Texas Department of State Health Services in Public Health Region 1, and I oversee our immunizations and HIV STD programs. I've been a registered nurse for 10 years with experience in cardiac critical care from the Lubbock Heart Hospital, and I moved over to PHR1 where I have been working with tuberculosis, STD, HIV, the COVID pandemic, and especially now with our measles outbreak. So we've been pretty busy. I am currently a PhD candidate with the School of Nursing with their BSN to PhD program at the University of Texas at Tyler And my focus is on dementia-friendly community initiatives in rural areas with hopefully an expected graduation date of December. So fingers crossed. And we have our lovely panelists. Thank you. We have our lovely panelists here today. So if you would just introduce yourself and go down there.
Hi, my name is Todd Bell. I don't know that I've ever been called lovely, so that's actually very nice. I'm glad I was included with the actual lovely people. So I'm primarily a pediatrician. I actually work at the Amarillo Health Department. I'm a local health authority. Have a little bit of ADHD, so I do several different things. But I've had an interest in One Health for a long time. Grew up on a farm. Actually, did a little time in vet school before I went to med school. And have always had an interest in the interface between human and animal health. So that's my guess as to why y'all asked me to participate.
Good afternoon. My name is Cynthia Reynoso Webb, and I am the Biological Threat Coordinator for the Laboratory Response Network, LRNB. I also manage the Biological Threat Research Laboratory at Texas Tech University. So I am in Lubbock. Our laboratory has research capabilities, but also public health capabilities and human clinical testing. Our laboratory is the one that identified the clinical case for the first clinical case for this outbreak of avian influenza. So it's been a pleasure working with DSHS Region 1, especially Dr. Abdul, and I'm here to answer questions regarding laboratory testing, and so on. We'll see where this takes us. Happy to be here. Thank you.
Hi, I'm Susan Rollo. I'm the state public health vet with the Department of State Health Services in Austin. I've been with the agency since 2021. Prior to that, I was with Texas Animal Health Commission as the state EPI for 7 years. So I do have experience in agriculture. I've been on a lot of dairies up here in the Panhandle. And I'm also, it wasn't a criteria for this panel, but I am from Lubbock and I went to Texas Tech. And so that's a little bit about myself. I'm a veterinarian and I also have a PhD. Thank you.
I am Stephen White. I am the high consequence infectious disease team lead for Department of State Health Services in Austin. I'm here because I was part of the H5 team at central office. So any time you hated us, that I was part of that. So I also have to give a shout out to my wife who let me be here because it's our 19-year anniversary today. So I feel remiss if I didn't tell her that. So she's watching. I also have a PhD from Florida International University and a master's and a bachelor's from Texas Tech.
Thank you, everyone. So as Dr. Abdul talked about earlier, HPAI with the H5N1 is a known zoonotic strain, and human cases remain rare, but very serious for that human-to-human transmission. However, she talked about earlier about 70 cases in the United States and 1 death. And the control strategies for surveillance and public health response is going to be the culling, the biosecurity, and PPE, which are the global standard. And there is that pandemic potential, as she talked about. It's a real concern due to the possibility of the genetic reassortment, particularly in regions with co-circulating avian and human influenza strains. And with surveillance and preparedness that are continuously ongoing priorities emphasized by the World Health Organization and FAO. So we'll start with our first question for Dr. Bell and Dr. Rollo. What early symptoms of HPAI infection in humans should clinicians look for?
Can we start? Okay. So, and I'm going to take just a real quick background. Again, as you guys know, HPAI have been around for a while. Historically, we've looked at HPAI in humans as being very severe disease, 50% mortality rate. You look at the context of that, and we're talking like in Southeast Asia is where the majority of these cases have been seen prior to about 2021, 22. And part of the context of that is that people had a lot of close contact, especially with poultry. And so anybody who has a walk-in chicken coop or hen house knows that oftentimes there's a lot of dust that gets stirred up there. And that's a little bit different of a context than when we're thinking about a dairy or somebody who might be dressing out a feral hog or some other interaction with animals. So what we've seen over the past year is that the majority of the cases, there are folks will have conjunctivitis, so basically eye infection or pink eye. It's actually can be a pretty significant pink eye, even with some hemorrhagic conjunctivitis. Folks can have typical cold type symptoms of runny nose or cough, or even headaches or muscle aches like we oftentimes see with the flu. Very rarely have we seen that pulmonary disease and that lower respiratory disease. And I think that part of the reason for that is that when we actually look at the sialic acid that the virus binds to in order to be able to enter a cell, the avian flu is adapted to a 2,3 sialic acid, and people primarily have a 2,6 sialic acid, so the virus doesn't bind real well. However, we do have 2,3 sialic acid in our conjunctiva. So when somebody has an exposure to the eyes, that's going to increase that likelihood, or it creates an opportunity for a virus that's not well adapted to people to be able to start causing infection. So it can start that eye infection. Interestingly, we also have 2,3 in the human lung. There's a mixture of 2,6 and 2,3 in the human lung. And so that may explain why when people have been exposed to, for example, poultry dust, and they're in, and again, you think about a majority world situation where someone has a large bird flock, and they get a lot of dust exposure, may not have some of the PPE capacity, that gets breathed down, and that potentially could explain some of the reason why we have the higher mortality rate historically compared to what we've seen in the U.S. over the past year or so. So again, primarily what we've seen are these mild illnesses that people get over fairly easily, but there's still risk of subsequent, either because of genetic reassortment or just antigenic drift, subsequent adaptation so that the virus is able to transmit from person to person.
I think Dr. Bell covered most of it, but with thinking about physicians and when they see a patient with upper respiratory disease, we think it's really important that they consider their occupation and their exposure as a part of their workup for the patient. And finding out that, a person works in a dairy or on a, with a poultry flock, that's an important risk factor to this disease, obviously. Also, maybe exposure to raw milk or processing or some of these other things that we don't think of right off the top of our heads. So we hope that clinicians will consider that when they see patients. Also, for the health department, we have been monitoring people that come back from depopulation of poultry flocks. Around the country, when contractors are used to depop poultry flocks, the CDC gets the contacts and sends it to the health department. And the health department follows up with those people and monitors them for 10 to 14 days after they depopulate. And I do think it's important too that, I don't think we really thought about conjunctivitis for a long time with that, because as Dr. Bell said, it's with poultry, it's more of a respiratory risk. And so we typically thought of respiratory disease. And I think Dr. Webb can comment about when we first had the HPAI, we didn't have a test for conjunctivitis or the conjunctiva. And so that was something that was new with the HPAI and with the dairy exposure to milk. So.
Yes. So when I got this call asking if we would test for H5, I was like, on what? For what? What kind of sample? I had all these different questions, right? And at the time, it was not a lot of information was out, so it was it was kept kind of tightly. It was tightly kept, and then they were saying, we have conjunctival swabs, and I said conjunctival swabs for avian influenza. And I said, sure, why not? I said, as long as you bring me a nasopharyngeal swab, I can maybe ask for forgiveness later. So I think that's kind of the role of the public health laboratory. We saw it at the moment. We had to ask that question: is this something that we're willing to do? And of course, at the time, it was much needed. Conjunctival or conjunctivitis was one of the biggest signs in that individual. So I said, sure, let's try it. And so when we actually tested the nasopharyngeal swab, the conjunctival swab, the nasopharyngeal was positive, but it wasn't as positive as the conjunctival. So that was really good information, actually, that we shared with CDC. I remember calling them that night, and I said, by the way, the CT values, like lab people think about these things. And they were, that kind of prompted sort of a lot of different questions from the laboratory aspect too, as to why we're seeing, higher basically amount of virus or a higher CT value in conjunctival instead of nasopharyngeal. So a lot of different things, we talked about, and our laboratory actually received the 13 samples the day before, I believe. They were negative, so we kept all of those. We sent those to CDC, and that helped them get their validations and a lot of things. So we worked very closely with CDC to help them, and they help us in testing this.
So quick question, on the 13 that y'all that we sent in, was that just oral pharyngeal or was that conjunctival?
Most of them were nasopharyngeal, but there were some that were paired. And so those paired samples actually became gold because there were very few samples that they were around. So actually the samples came to us. They went to, when we figured out they were negative, they went to DSHS in Austin to be tested for a whole respiratory panel. And then I said, make sure you don't trash those just in case. So they came back to us, and then they went to CDC. So they took a tour of Texas for sure.
Sounds good, thank you. Okay, question number 2 for Dr. White and Dr. Bell. How do public health departments coordinate HPAI responses with hospitals and clinics?
Well, speaking from the central office standpoint, I look at our role as one of support, both for our local and regional health departments as well as for our healthcare facilities. So one of the things that we tried really early on was to get guidance documents created and out into the hands of our local health departments so that they could go and talk to our healthcare facilities, talk to those infection prevention and control folks, and all the interested partners so that they could do their investigations and also, help their communities. So I think things like this, where we get together as a community and we kind of establish those relationships early on. I know if you've ever been to one of these things, you've probably heard that ad nauseum, but I really think they're really important. I met Cynthia before this all happened, so we've had that relationship, and that relationship has gotten us through measles too. So those relationships are really important. I also, in thinking about this question, I think there are both formal and informal lines of communication that we have. Talked about some of those formal lines, like the guidance that we create, the investigation forms, those kinds of things. Also think about health alerts and health advisories that you get from DSHS when things like this happen. But then those informal or more informal types of communications where public health folks go out and talk to like the Texas Medical Association or other interested groups, the vet groups out there, and the infection control preventionists, all those different types of organizations. A lot of what we do is really communicating what's going on with those groups so that they can then communicate with their constituents. So I think that's from a central office standpoint, that's how I kind of look at it.
Yeah, I'd agree with that. In my mind, it depends on where you are in the public health or on that public health continuum. At one end, you kind of have the central state office, and I think that's I typically think of the state as being a source of guidance and a source of resources. And then at the other end of the extreme, you have the local health department like where I work. And there I think of it being more of a collaboration and coordination role. The value of the resources and guidance coming from the state is that they're able to pool a lot of knowledge and those resources and be able to fill in where those gaps are. The value of the local health department is that I'm the expert in our community, and so there are times that, again, those informal lines of communication really are key. So I've found out about HPAI in our local area because I happen to be drinking coffee with the dairyman who runs the local dairy. And that's an informal line of communication that has value and is hard to replicate on a state or a federal level. Likewise, the CMOs at the hospital, or somebody had texted me actually just a minute, not about HPAI, but a local geriatrician with a measles question and texts, and there's an access there just because we're a small community and we're able to coordinate and communicate sometimes, I think, in a more facile manner than what the state or certainly the feds can do. However, there's absolute limitations to what the local health department can provide. We can't do our own genotyping. We can't shoot. Sometimes we have trouble finding swabs. So there's that real need to be able to coordinate and collaborate back with the state and regional health departments as well to be able to make the system work.
I think adding on to that real quickly, from a like at central office, we think of things from a statewide perspective. And so I think what Dr. Bell said there is really insightful about having that access to your community and knowing your community, because we can provide guidance, but if we don't know what the needs of your community are, or not even not knowing them, but thinking more broadly on the state level, you can take that guidance and tailor it for your communities.
So from the public health laboratory perspective, there's 10 LRNs in Texas, and each one of us has a region. Usually, we're distributed in many different ways. We have 67 counties. Other LRNs have much fewer counties, but higher population. But in either way, we are all distributed throughout Texas, and each one of our regions is very different. So the LRN in Lubbock that serves part of the northern part of the Panhandle, where it's still considered frontier, some of those laboratories is going to have different challenges than Houston Health Department, which is dealing with millions of people. So I think that from the coordinating response from the public health laboratory perspective is different, because we have this ongoing communication and relationship with those laboratories, all of the laboratories that are serving these our regions, but also local health departments, regional health departments. And this is something that it's ongoing. So we reach out, every time there's an outbreak, or there's a health alert, or hey, there's measles testing, coming up. We maintain those communications. We visit them, go to the labs, try to do training. So maintain those relationships is really important, to the point, pretty much to the point where a lot of people have my personal cell phone that would just text like, hey, what do we need to do about this? That's just the life, I guess, that you sign up for when you work for public health. But also we take, once the different assays are kind of given to our laboratories, or we start testing, we create also our own guidance documents, of course using everything from the state, but it's more specific as to where to drop it off, what are our hours, who to call, what kind of questions. We try to anticipate those potential issues that may come up, and so we issue that to our region, and then just kind of take it day by day.
Thank you. Question number 3. This is for Dr. Rollo. How do public health departments coordinate HPAI responses with veterinary partners?
In a very similar fashion to what the others have said about the human side, we also do this on the animal side. In Texas, we have Texas Parks and Wildlife. We have veterinarians there. They're sitting over there in the corner. We have Animal Health Commission. We have DSHS, Zoonosis Control. We have vets in all the regions. We have the Texas Veterinary Medical Diagnostic Lab. And so one of the first things I did when I came on as the state public health vet is I called them One Health. Okay, it's maybe an overused term, but it was really a coordination and communication interagency working group. And so I pulled the leadership from all those agencies together, and so we met in person. So we had face-to-face meetings. Everybody has each other's cell phones, numbers. We call each other on a regular basis. We meet with each other on a regular basis. And we were meeting twice a year in the beginning. And as these topics have come up, specifically HPAI, we had a lot of ad hoc meetings, and we've increased our, expansion of the members that participate in our group. I forgot to mention that we have our federal partners as well, USDA, APHIS, as well as Wildlife Services. So we develop these relationships in peacetime and in blue skies, as Dr. Martinez would say. And then during wartime, we're able to work really effectively together. And I feel like we've done a really good job at communicating between groups, and we have established relationships, and I feel like we've done a good job in Texas with that part of things.
Thank you. Question number 4, and this is for Dr. White and Dr. Webb. How can diagnostic labs quickly differentiate between seasonal flu, COVID-19, and HPAI?
Well, I'll talk about, I'm going to deviate a little bit and talk about our surveillance for influenza and H5. And then Cynthia can follow up with the laboratory part of that question. And I'm sorry, I am the B team here, right? So I do have notes here that I need to reference, or else I'll talk for about 20 minutes. But the influenza surveillance in the state of Texas and across the nation largely is built up of a couple of different fundamental programs. The first and foremost of that is probably ILINet, which is where we have clinicians that report how many influenza-like illnesses that they see in their offices. And they report that data to the state, and that gets compiled at both the state level and I think the local levels as well, and then at the national level. So when you see that influenza data from the national level, that's where a lot of that data comes from. Dr. Well will talk about laboratory-based surveillance, but this is when we send them specimens, just like we did with H5, and we get our rapid subtyping results back. There are other things like mortality surveillance, where we look at how many pediatric deaths there have been. Those are indicators of what's going on in our communities. We also have syndromic surveillance, where we look at clinical illness across healthcare facilities. The state is really valuable, and we use it quite a bit during the H5 experience, just as kind of a double check to make sure that what we were seeing in the field is what we were seeing in hospitals and clinics. One of the kind of the newer surveillance tools that we have is wastewater surveillance. I personally think wastewater is pretty cool, and it's not just because my dad built wastewater plants that I got to play in when I was growing up. But it's a really cool surveillance tool that we can sample large populations and figure out what's going on in those communities. And so we did use this quite a bit during H5 as well, and influenza surveillance more holistically. So what they do is they look at detections in that wastewater. And there's a couple of organizations that are really working on that in the state of Texas. TEFI is one of them. TSHS is running some programs, and then we've contracted with the CDC. The CDC provides contracted testing services as well. And those results are on the CDC's website if you're interested in checking those out. The other thing I wanted to touch on is, as you heard Dr. Abdul mention earlier, a lot of what happened with H5 in cattle was noticed by the vets that were treating these animals. And it was that clinical recognition that something was going on here. And I can think of a couple of other examples where it was, that first line provider that really picked up on what was going on. I worked in Florida for 10 years, so very knowledgeable about the anthrax attacks. And it was a knowledgeable doctor that saw what was going on and referred it out to the labs for testing. So all of these pieces kind of come together and provide kind of this comprehensive surveillance program that we have in Texas. Good.
So our laboratory, as a public health lab, participates in the influenza surveillance program, and we mainly do the clinical testing aspect of it. There's like Stephen mentioned, there's several different aspects of the program, but in communication on working with all these different partners in our regions, we ask them to save samples, a certain number of samples of positive flu samples, and send them to us. And when they arrive, we do subtyping. So we, for influenza A, we look at, we test for A and B. And then if it's A positive, then we look for basically H3 and H1N1, which is 2009 H1N1. And then if those are negative, but it's flu positive, then we, our eyebrows raise and we go to H5, H7. If it's B, actually, we haven't seen Yamagata since COVID pretty much. So that aspect has kind of dropped to more of a research aspect, because everything that's been circulating has been Victoria. But basically that's kind of what we do. We take the best samples of what we receive within a certain number of days, and then those are sent to the state, and the state will do something similar and then send to the CDC. And so these samples are eventually maintained, and the results, I guess the cumulative results and the different strains that are going around is what is going to inform the CDC for the next flu vaccine. And so it's a huge effort, coming from all kinds of, from very rural laboratories all the way to CDC. These samples kind of make it their way there. And so every week we report what we see as far as what subtypes we're seeing during, after H5, actually last year, and at the beginning of this year, we really started the enhanced influenza surveillance program. And that really depends on what the capabilities of each lab and kind of what the population is like, what are the needs of our population, right? So some of our biggest laboratories, they, as soon as they get a sample, they just put it in, they could put it into a respiratory panel and test for many different things. They're looking for RSV, flu A, flu B, COVID. They can test for anything you like, rhinoviruses, etc. But there are other laboratories who don't have that capability, or if they do, it's going to be very expensive. So we had to really work with our partners, work with our laboratories, and say, what do you have? What do you need? How can we help you? So we still maintain the same submissions from the bigger laboratories, because a lot of those are hub type of hospitals, like in Lubbock. There's a lot of people from outside of Lubbock that come to Lubbock to get treatment. And so that's where we can really catch a lot of those samples from all over the northern part of the Panhandle. Same thing with Amarillo. But then we work with some of the smaller hospitals, and we said, okay, anybody who has severe illness, who's had contact with animals, who is in the ICU, for example, any pediatric cases, if you can't subtype in your hospital, send them to us and we will do the subtyping for you. So we really had to kind of tailor our response based on what their needs were. And so we increased the number of samples, our intake of samples by, I don't know what percentage, but it was a lot. So we're testing hundreds of samples many times a week. And, we did screen several of those for H5. We didn't find any H5 positives, but we were looking for sure.
Let me.
And,
let-
oh, go ahead.
Sorry, I meant to add one other thing, and it wasn't in my notes, and that's why I didn't say it. But Dr. Rowley touched on our monitoring of people that have been exposed. And this is really important, especially when we have known exposure events. And that's when we have these identified folks that have been exposed, and we're monitoring them for symptoms for 10 days. And the local health department is usually doing that. And so that allows us to quickly get to that person if they start becoming symptomatic, and we could get samples to the labs really quickly that way. And really, from a public health standpoint, either rule it in or rule it out.
Okay, thank you. And on a side note, if there's in-house testing that is performed, clinicians need to contact their local health department if they're unable to test for flu type A and B, and if the flu test is positive for flu A. Question number 5. This is for Dr. White, Dr. Rollo, and Dr. Bell, if you want to chime in. Based on the current data, what is the likelihood that HPAI will continue to spread?
So I think we've touched on this a little bit before. I know Dr. Abdul talked about the PB2 gene mutations that's been detected in cattle in Texas. And Dr. Bell mentioned the salicylic acid receptors. Those are two kind of key mutations that we look at to see, or that we think will confer or help confer transmissibility from human to human. And so the way I look at this, there are two kind of related things that I look at. And one is that genetics, right? Are those mutations in what we're seeing? And then the other part of that is taking samples from people and animals to see what's going on genetically. So yeah, we're looking for those mutations, but are we actually seeing that in real life? So with a lot of the human cases that we've seen over the last year, CDC has taken a very proactive stance in trying to get those specimens and sequence them and looking for those mutations. And the good news is we haven't seen that salicylic acid receptor change too much. There's been a couple of cases. There was one case in Louisiana, an individual that passed away that had some of those mutations at low levels. So they can also look at the virus. We tend to think of viruses as static, right? It's this way, but really they're always changing in our body and from person to person or from animal to person or however it goes. So some of those mutations were seen in that individual. But they're believed that it was because this person had such a prolonged illness and eventually died from it. So that's the good news. The other way that I kind of think about this is just in time, right? Think about driving. When you drive, right, you're at risk of having a wreck. The more you drive, the more at risk you're at, or the higher chance that you're going to get into a wreck because you're exposing yourself longer. That's how I tend to think about this situation. The longer that we kind of let H5 go unfettered and without our control, the longer that virus has a chance to mutate. And the more interface between that human and animal interface allows those, or potentially allows for those mutations to occur. One other thing that we kind of think about is at that interface between animal and human is humans bring their own influenza viruses into the scheme as well, as Dr. Abdul mentioned. So if a dairy worker has H3N2 and then they're exposed to H5, those viruses could get together and reassort, creating something that's a little more transmissible. So the longer we let that go, the more opportunities we give that virus to do those things.
basically, he pretty much covered it, but on the same note with animal populations. For a long time, we've had a avian influenza surveillance plan with poultry. And whenever we saw a low pathogenic avian influenza, we would also try to depopulate that flock for the same reason. We don't want that virus on the landscape having time to mutate. And so as far as the overall question, it says, based on what's the likelihood that HPAI will continue to spread? I mean, I think that's the $100,000 question. I mean, this virus has been very unpredictable. We never thought we would see it in cattle. And so it just seems to find these niches and these new places to pop up and surprise us. And so it's really hard to predict what's going to happen in the future. But I do think we should be prudent with the potential of animal spillover to humans, because humans, there's a big population of humans out there, and that could be a sign that would be a place for this virus to go.
I would probably take a little different approach to the question, I guess. And please, I don't want to end up being a Last of Us meme, and please don't think that I'm alarmist. But I actually think the risk of us having an avian influenza pandemic approaches 100%. And the reason is, now, not this year, probably not next year, probably not the year after that. I don't know, 5 years, 10 years, 20 years, 40 years, I don't know. But I tend to think of it as a chutes and ladder game. Anybody play that when they were kids? And so if you happen to land in the right spot, you get to climb up the ladder and get closer to winning. And if you land in the wrong spot, then you actually go back down, and it puts you back closer to where you started. So it's kind of like chutes and ladder. The virus goes along, and there are times that it'll hit some sort of amplifier which functions as a ladder and chutes and ladders. So getting into dairy cattle, that was an amplifier. The massive quantity of virus that's produced in bovine mammary tissue, that's an amplifier. Each time that it has an opportunity to interact with new species, including people, that's an amplifier. There's also chutes, right? So it gets to be summertime. It gets hot. We have behavioral changes amongst both animals and people, and that sets it back. But the issue is the virus continues to play the game. And every year we get to restart doing this same thing. And at some point, the virus will win, or we will have developed some universal influenza vaccine. And from a human perspective anyways, then we're in good shape. So please don't think I'm alarmist. What's the risk of us having a pandemic in the next 6 months? I think really small. What's the risk in the next 12 months? That's a little higher. What's the risk in the next 5 years? Well, I think that is actually a fairly significant risk. What's the risk in the next 15 years or 20 years or 40 years? Again, you give the virus long enough, because of this ongoing continual mutation, eventually the virus wins, because that's how the game's set up, right? We don't have a mechanism to be able to eliminate H5 or H7 or even our low pathogenicities. We don't have a way to be able to eliminate them from all the potential reservoirs. That technology just does not exist. And so we're going to keep playing the game. And I think that's the reason that we have to be able to invest as a society in these monitoring mechanisms, invest in those relationships between different aspects of the response, so that when it does come, and again, best I can tell, not if, but when it does come, hopefully it's after I'm retired, but when it does come, those relationships are built and we're able to respond in a way that's most effective in order to be able to mitigate the risk.
Thank you. Number 6, this is for Dr. Rollo and Dr. Bell. How does HPAI accentuate the need for One Health?
So one of my new favorite quotes is that pandemics begin at the boundary of arbitrary jurisdictions. So almost by definition, a pandemic has to happen at a point where we have one jurisdiction, whether that be a species jurisdiction or whether that be a geographical jurisdiction, that's where pandemics start, right? Because pandemics don't start in poultry. Pandemics, at least from a human perspective, start when a poultry interfaces with a people, or a poultry interfaces with a feral hog. Those are the opportunities that the virus has to be able to adapt and be able to start infections. So, and I think it was highlighted earlier, Dr. White and Dr. Rolla had mentioned the communication component of that. And I think that one of the things that is potentially missing in One Health is being able to replicate that same cross-jurisdictional, cross-agency communication at a local level as well. And we haven't historically had those sorts of interactions at a local level. I don't routinely meet with our animal control folks at the city of Amarillo. I should, because it turns out we have bird die-offs, right? I don't routinely meet with the wastewater folks, and I probably should, because it turns out we have actually the first HPAI identified in municipal wastewater in the U.S. was in Amarillo, and had to do with a industry that we have that they were shipping milk in. But it certainly got our attention when all of a sudden we had H5 showing up in our wastewater. So we've got to do, I think, from a local health department standpoint, be able to interact better with other local folks, and not just folks that follow the same chain of command as what I do. So I need to be able to interact with our local TAHC folks. I need to be able to interact with our local TPWD folks. And sometimes those are really difficult relationships to develop, especially when there's angst and issue going on. So when I pick up the phone and I start calling somebody after we get H5 in the wastewater, man, I get a lot of ringtones and leave a message after the beep, because that's not the time to be able to build those relationships. I think we got to build those communication relationships now in anticipation of when we have an issue further down the road.
I'm really glad you brought up the local. I really like that idea, because I do think that's important, because you also don't eat breakfast with your local veterinarians too much. I mean, the doctors, and they have their world, and the veterinarians have their world, and how to connect those two groups of people. As agencies, we can facilitate that with these types of meetings like this, where we have a mixture of audiences. And you are able to go meet your animal control officer and that kind of thing. So I think that's where we play a role as a state, and in collaboration with other agencies, is trying to bring different groups together. And I really do think we need to emphasize more on the local, like you're pointing out. I think that's a very good point. And we as veterinarians, we think on the population level, so we have it in our mindset. We're experts at this. We manage dairies, and we manage big populations of animals. It's a lot different from a physician's point of view, where they have one patient. And so how to look at veterinarians as assets to pandemics and to outbreaks. I think it's an important relationship that we should continue to develop. Thank you.
Thank you. And our last question. This is for Dr. Webb and Dr. Rollo. What are the top priorities for research and funding to better prepare for HPAI?
So like I mentioned before, our laboratory is also a research, we have a research aspect of it, because we're in an academic institution. So there's funding that's recently been put out, or like funding mechanisms from FDA, and some of the things that that come to mind are there's funding for vaccine development, for looking at transmission, environmental transmission, looking at different different species, but also different vectors, mechanical vectors, et cetera. We're putting in our laboratory, we're putting in some proposals to do some work with HPAI. I was mentioning to somebody that HPAI H5N1 is a select agent under USDA, but last year there was an exemption. There's a 3-year exemption because they wanted to allow basically more research. It was like an incentive basically to allow more research to be done with H5N1. So I don't know if that's going to be renewed or it will continue, or once the 3 years are done, then it's going to go back to being fully regulated select agent. But it certainly helps in promoting more of that research.
For the animal side of things, I know it's been a challenge for the USDA to re-simulate the whole idea of how HPAI got into cattle, the first spillover from the bird to the cow, which right now we know there was the first single spillover event in the Panhandle, but there's also been another event in the western states with a different strain recently. And so how that occurred, it's been difficult for USDA to replicate that. We also don't really know how it spread between herds. We know obviously there's risk factors, transfer of cattle, people, all those other things that are listed as risk factors, but we don't know every single scenario. It doesn't fit in every single scenario. There's scenarios where the herd is, completely isolated and still got it. We don't understand how it spread from the cattle to the poultry other than proximity and geography. So those are some of the questions that we still have that we need answered. It'll help us better understand that. That's one reason why we are trying to do our part, as well as Texas Parks and Wildlife, and testing additional animals, such as using the brains from the rabies negative to test for the mammals, so that we can increase our research, information in general about the virus and how it spreads. So I think that's where we need funding, and I know they're also developing vaccines. I'm not up to date on all that research on the animal side, but that obviously is another area that is being considered.
Any other comments? Okay, that's all the questions I have. Thank you all very much. Oh, I'm sorry.
No applause for us.
I knew it wasn't over with Dr. Abdul coming up here. It just, no hard questions. That's all we ask.
We've got a
Softballs
few.
only.
Sorry. We have some folks online that are attending online. And first question is, it says, hello. This question is for whomever wishes to answer. My question is this: with the ever-present possibility of an avian influenza pandemic, what surveillance systems would you suggest prioritizing, as public health funds are always limited? Thank you. And this is Shelley Stone Cipher.
Well, I think the first thing I would prioritize, and we've been doing this in Texas, and I think Dr. Webb can talk about this a little bit too, is we've been trying to beef up the surveillance systems that we have, right? We've been, our laboratory, our DSHS laboratory, as well as our statewide influenza coordinator and some of our other staff have gone around to the various regions and various local health departments and facilities in those areas to try to get clinicians and facilities to actually be part of ILI-NET. And then part of that goes along with it is submitting those specimens for characterization. So I think that's, that's kind of where our bread and butter is, at least from my perspective. I would also plug in, just because I think it's so cool, is wastewater surveillance. Wastewater right now is kind of a hodgepodge of all those different programs that are going on. And to bring that data together is really where the power there is, I think. If you look at the map of Texas with the wastewater sites, there are large swaths of area that have no wastewater monitoring. So there are opportunities there as well.
I certainly agree with that. I think it's really important to look at, especially severe cases, anybody with going into the ICU with influenza, we want to make sure that we know, there's some terminal testing, there's some subtyping of those influenzas. A flu A positive, it doesn't tell us anything. It actually opens more questions. So in my communication with all the different laboratories, I talked to them a lot about this, and I said it's really important that we get some answers on these, very severe cases, ICU, anybody who has extensive travel, anybody who has, a lot of contact with animals. So somebody that could probably work at a dairy, or probably works with chickens and any in any way. So just making sure that that we're getting some of those answers, and as they're implementing subtyping capabilities in all these different hospitals, I'm just trying to make sure that's they keep in mind that it's really important that we get those answers.
I would actually say that the at this stage, anything that we can do that's able to do active surveillance at a animal-human interface region is something that is missing, I think, right now. We're doing the monitoring, as was mentioned. We know that there are some folks who have asymptomatic infections. That happens with any virus, right? So even things like Ebola, 15% of patients in the beginning of the 2014 Liberia outbreak of folks in Liberia that they tested already had antibodies to Ebola, and they didn't remember ever having it. We know that in dairy workers, 7%, or I'm sorry, 7% was a study that was done in dairy workers in Colorado that was published in November in 2024. So we know that there are opportunities there where people are getting infected. And I do worry a little bit that if we depend too much on some of the things like syndromic surveillance, especially where we're looking for respiratory illnesses presenting to the emergency room to rise above the level of background epidemiologic static, then the pandemic is already established at that point. As a general rule of thumb, I always think, hey, if we have 3 transmissions, then the influenza virus is now adapted to its new host. So if I have 3 people, one person gives to somebody else, gives to somebody else, all right, I already have a virus that's adapting. And at that point, it's going to be really hard to be able to stop a pandemic. We'd still get early warning, but we're not going to be able to get it stopped. So I think that if we're looking at trying to abort a pandemic, I think that we have to figure out how to better survey folks at that human-animal interface, or potentially at the animal-animal interface, to better understand how it's being transmitted from one place to another. Yeah, so the great question. In Texas, and this is going to keep me from ever being invited to one of these again. So in Texas, I think the response was suboptimal. Now, I think that the reason for that is not because of any issues with DSHS or the good work that these folks are doing or the things that I'm trying to do. The reason is that there was a lot of money on the table. And so when we start having, especially a new outbreak, and we have an industry that feels like it's being threatened, the risk is that folks just sort of clam up and say, there's nothing to see here. Now, we as a country have set up a deal where there's a financial risk for a agricultural producer to be reporting a new pathogen or an outbreak of a pathogen, and that financial risk falls back on the producer. We don't have a mechanism At least we didn't have a mechanism, especially in dairy cows. Now there is a mechanism in poultry for culling and some things like that, but it still doesn't cover the cost of the financial burden that producer has. So I think that especially early on in this, our response was less than what we could have hoped it to be. There was a lot of surreptitious phone calls that were reaching out to people and saying, hey, any chance that we could just come by and just, hang out outside your ranch and offer folks to be tested. Again, those types of things, we've got to figure out how as a society to be able to encourage and motivate folks to actually be reporting and participatory in the process, as opposed to needing to be able to cover their heinies or protect their livelihoods. And I don't know that we've figured that out quite yet. I think some states have done better than we have. But that's something we're going to have to sort out at some point to be effective at doing this.
I'll try to be a little more optimistic since my boss might be watching. And I'm not a local health authority.
I have some liberty here that some other folks
Yeah.
might not.
I think what Dr. Bell said is right on point, right? This was a hard situation. This is what I've had some conversations with my non-public health friends, and some that are kind of the same suit, where it's like, why didn't y'all do more, that kind of thing. Like, it's a hard situation. We're talking about millions, if not billions of dollars. We're talking about people's livelihoods. Having said that, to answer your question, I think we did develop some ideas of doing more enhanced surveillance in and around the area. Not all of those suggestions were taken, but one of those that we did do was we really lowered the bar for testing, I think. There were times when we had reported cases of illnesses on some of these properties, and the ideal sampling time for those collections had probably passed, at least for most of those individuals, but we still tried, right? And that's not something we probably would always do. We did more sampling, I think, for this, and in those types of populations. People with better memories can probably back me up or tell me I'm wrong. So I think that's one of the things that we did, was we lowered the bar to testing, much like what we're doing with other things, in an attempt to try to identify those cases in the population. So it's not a perfect answer, and I tend to agree with Dr. Bell, but we did do some things. Yeah.
So our laboratory, when this happened, when we reported the first positive, I thought a wave was coming. And so we really geared up for high throughput testing, and we were validating, new instrumentation, what else we can do, kind of like this is our first year of preparation. What's our next? Just waiting for a wave, not hoping. But nothing happened. And so I think that's part of the mentality of Texas, like this is mine, and you can't just come in and ask to test everybody like it happened in other states. Probably in other states that were more willing, but that would have been the perfect thing. I feel like from the public health perspective, we were very proactive, and I know the region was very proactive, really tried to go out there. Everything was pretty much set up for a lot of testing, but it just never occurred. We lowered the bar, like you said, and I personally reached out to all the different hospitals that were right there where the first case happened, but also around. And I said, what's the situation with flu testing? What do you have? What do you need? How can we help? And we really, tried to work with those individuals to make sure that we gave them as much support as we could. We even sent BTM, anything that they needed at the moment, But again, people were not just lining up to be tested, and so it's a hard situation.
Next question for the LRN. I remember as a lab tech that only certain personnel could test for mpox. Eventually, there was a change in who could perform testing for mpox. My question is, who classifies certain testing protocols for only certain personnel, and would this apply for influenza testing as it had for mpox?
So I think that's probably alluding to the different biosafety, I guess, surrounding whatever you're testing, initially. So public health laboratories, it's a whole network. And we all have BSL-3 capabilities. We all have very standardized instrumentation, training, testing, things like that. So assays are usually deployed first to LRNs because they say, okay, all the LRNs have this one instrument, and so CDC can very quickly deploy assays to our labs. So I think that's what they're talking about, and so and we can, we will test the BSL-3 or BSL-2 enhanced, depending on what it is, and then usually as more information comes out, as they figure out a better or a way to make testing safer, then it can probably be tested at BSL-2 and so on. So I think there's a lot of testing that's performed, influenza testing that's performed at BSL-2. So that's not the problem at all. For H5, I honestly, off the top of my head, I'm not sure. We always use BSL-3 precautions just because we want to be careful. But certainly seasonal influenza is tested at BSL-2 in a lot of different places, and even over the counter with point of care testing. So there's a lot of options for sure.
I'll add to that, and I think Dr. Webb is right. Like one of the things with that testing, and I'll speak from mpox. I'm also a former lab director, so I feel like I can talk on this a little bit. With mpox, like that assay was at the LRN laboratories first, and it's a lot of the testing that like the labs like Dr. Webb's lab does is very esoteric. It's once or twice or three times a year is when you're running that assay. So if I'm a commercial laboratory trying to make a little bit of money on the side there, like there's no reason for me to have that orthopox assay because I'm only going to test maybe one or two patients at any given time. Mpox, as a really good example of this, changed that. And Mpox is one of my conditions. So I really love that the CDC provided that assay to five commercial laboratories really early on in the outbreak, because that opened up the testing to those laboratories. But I don't think it's necessarily gatekeeping that they're doing. I think it's a matter of, your laboratory has that experience and that high level of training for those types of agents. Before 2022, mpox wasn't a thing that we really cared about too much on such a large scale, right? So, looking at H5, the same thing has happened too. Like you guys have the H5 subtyping assay. There are some commercial laboratories that can do that now. And that's because they've decided that it's worth their while to bring that assay on board. So I think a lot of that really has to do with who has the assay to begin with, and also some of the financial considerations thereof.
Yes, for example, because our laboratories are CLIA, they're CLIA certified. So we have to be able to maintain that assay, we have to have, proficiency testing and all kinds of, training for personnel, semi-annual training, annual training. We have to do validations on different instrumentation. So there's a lot that goes into maintaining a test that may be used once in 5 years. And I remember actually that just a few months before that, we were talking about H5, and I said, what's the likelihood that we're actually going to use H5? And then boom. But when it, we got that phone call on the weekends, because all of these things happen, Friday to Sunday. we got that phone call, and I said, okay, we're ready. We just, got a new lot of H5 primers, and, we've already run positive controls. We know it works. We know it's there. We're ready for it. So part of the role of the LRN is also maintaining these assays and kind of pouring into those, just being ready, just pouring into those assays that may not be used, but when it's time, then we're prepared.
Another, not to belabor the point, but or another really good example of how the LR of this, but at a different level, was the H1N1 assay. Was originally only performed at the CDC, and then they started giving it out to the LRN laboratories, and now we see it at all the commercial laboratories because it's a widely available test. So, and I think all of this too was especially. This was a really critical lesson learned during COVID, and sharing the love with who could test for COVID. Because I remember being one of the first labs that could test for COVID, and no one else could, and it was a race to see who could get that assay up in the commercial laboratories. Because when we have events that big, or we have impods, I don't think we had the public health laboratory capacity to handle impods either. Maybe a little better, but so, we public health people get a little upset with lessons learned sometimes and how they're not always learned, at least not year to year, it feels like. I think this was a really good lesson learned that we've continued to build on, thankfully.
Okay, we just have a few more minutes. I'm sorry. How is the current administration with cutting funding for essential agencies going to affect the LRN and other organizations? That's a hard one.
I always try not to be political in public, at least. It has affected. Funding was pulled from all the health departments or public health laboratories, so it has affected. It's definitely going to affect the response. We're just trying to leverage. Honestly, we had a public health lab directors meeting in Texas just last week on how do we reinvent ourselves? What else can we do? How do we keep the doors open? How do we keep our staff? Because of what we do and the level of our laboratories, we have very specialized staff. We have, you can't just take somebody out of high school or out of undergrad or even grad school and be like, here's an assay, go for it. It takes a lot of training. And so we've invested a lot into our personnel. And so we just continue to figure out how we reinvent what we do and what other services we can provide. We don't charge for any of our testing, so that's really not a source of revenue. We can just say, well, let's just do more testing, because all of our testing is free of charge, but we just try to figure out how to, what else we can do, basically.
Okay, and the last question here is there an HPAI tracker similar to trackers used during the SARS-CoV-2?
So, as far as I'm aware, no. And just to kind of clarify the question a little bit, I think what they're probably referring to is Hopkins, for example, had a really nice population map that was a global population map that they actually tracked, especially early on, what the number of positives were in a particular area or geographical area in the U.S. As far as I'm aware, and certainly as far as where that data is available, I'm not aware of any sort of collated information like that. Although
With the animal data, the USDA has a website. And if you Google USDA and then HPAI, you can get to the website, and it has 4 blocks. One of them is for poultry, one of them is for wildlife, one of them is for cattle, and what's the 4th one? No, it doesn't, we don't have the people on the USDA website. No, we have it's cattle.
Someone put a comment here that says it tracks positives in waterfowl, poultry, mammals, and livestock.
Okay, yeah, mammals. So the 4th thing is the mammals. So they have the waterfowl, the birds separate from the mammals. And so the mammals would be like the skunks and the raccoons that we've had that have been positive, the seals, the bears, all those. And so there's a map, and it shows you where the positive are. You can also download the data and get the dates from that, and the same with all the other 4 links. So yeah, there's a tracker for the animal data on that website.
Yeah, I'll say the CDC also has a lot of the data that is collected at the state level and kind of coalesced. It's not that dashboard format that we all got used to during COVID, but it's got a lot of good data on their website. I mentioned the wastewater site beforehand, so you can go and look and see where all the sites are, not by name necessarily, but by jurisdiction and location. They keep, much like the USDA site for animals, they keep track of the human infections on the CDC website, so you can go and check that out. They've also got all their guidance and the technical reviews that they've done on the sequencing that we've talked about today, and all sorts of stuff. So it's a good resource. Also, shameless plug for our Texas Viral Respiratory Disease Surveillance Report that we put out weekly. A lot of good state and local and region level data in that report. Not necessarily on H5, but all respiratory.
Okay,
stuff.
for the last 2 minutes, for our panelists, any closing remarks you'd like to make?
All right, I'll take 60 seconds of that 2 minutes. So I think that even more fundamental than funding costs or funding reductions, and that has been there's lots of research challenges now. There's lots of public health challenges. More fundamental to that than that, I think, is that somehow in public health we have lost the trust of the public, and for whatever reason that is, I think that fundamentally one of the things that we have to do is figure out how do we reconnect with folks so that they trust what we're saying is correct and true. And part of that obviously is transparency. Part of it is messaging. Part of it, I don't know what it is, but we got a measles outbreak going on right now, and we've got folks that still don't want to get the measles vaccine. Hey, that's been around for 50 years, and we're really, really comfortable with the safety record for the measles vaccine. Not saying that nobody in the public trusts us, but we see this growing mistrust in public health, and that's a fundamental barrier that we have for successful implementation of any risk mitigation strategy. If we can't get the people to do it, then it's not worth a whole lot. So if anybody has any fixes for that, we're available to talk to. Please tell us how we do that. And anyhow, that's my beef.
I'm sorry, everyone has 2 minutes. I'm sorry, I was just told that.
Oh, okay.
Except for closing.
I'm done with mine.
I will abstain so I don't say anything incriminating.
Not if you don't want to.
Well, I'll just say that I mean, trying to have programs like this one sponsored by TEPI, where we're again at the local level bringing folks together. We also have the capacity of having it virtual, so we have people from all over the world apparently that are listening in. These are great ways for us to continue to do outreach, identify who we are, so they can call us and ask us a question. Working with our local vets, if we can somehow get the vets and the physicians together, that would be great. And, you know, those kinds of ideas, I think that's what we need is, you know, bouncing ideas off of each other and learning from each other and developing those communications. So I really appreciate the invite to be on the panel today. And I hope that, you know, people walk away with some new information.